This is our first lecture as a part of the series of the video lectures for the neuroanatomy. We'll start it from the third nerve pathway. The purpose of this video recording or the lecture is basically to simplify completely the courses of nerves for you so that you can easily understand them. And once completed with these lectures, you can read it from any neuroanatomy book. So start it with the third nerve. This is basically the midbrain, as you can easily see. The cross-sectional view, the simplest cross-sectional view which is possible at the level of the superior colliculus. Here you can see this is the dorsal midbrain and this is the ventral midbrain, right? Now, this area is basically the periaqueductal gray area, as I've marked here, right? This is aqueduct and this is periaqueductal gray. These are the paired nuclei which is in close proximity to the aqueduct here, right? This is the red nucleus, substantia nigra, crus cerebri, right? So the third nerve vesicles coming out from the oculomotor nuclei, they travel through or near the red nucleus, right? They crosses the substantia nigra and in the interpeduncular fossa, they came into the subarachnoid space. When the third nerve vesicles coming into the subarachnoid space, they are coming in close proximity to some very important structures. One is the superior cerebellar artery, the posterior cerebral artery, and the posterior communicating artery. So it is running almost parallel to the posterior communicating artery here. From the subarachnoid space, it travels towards the cavernous sinus, and at the cavernous sinus, there are certain very important structures which need to be remembered. One thing is that it is also in close relation with the pituitary gland here. And then from the medial to the lateral, the organization of the nerves would be third, fourth, sixth, V1 and V2 distribution. Here also you can find the sympathetic plexus, which is basically near to the sixth nerve. From the cavernous sinus, it enters through the superior orbital fissure into the orbit. Here there is some change in the organization, that is, basically coming in contact with the second nerve, that is the optic nerve, third nerve, simultaneously there with the fourth and the sixth, but only the V1 distribution is there. Before entering into the orbit, it divides into the superior and the inferior divisions. This is the simple diagram of the pathway of the third nerve. One very important thing which I need to explain you, that is the organization of the oculomotor nuclei. There are paired oculomotor nuclei which are located in the dorsal midbrain, as I've told you. Each nucleus is composed of the superior rectus subnucleus, here it is, providing the innervation to the contralateral superior rectus. Inferior rectus, medial rectus, inferior oblique subnucleus providing the ipsilateral innervation. So it's very easy to remember that we have four muscles which are being supplied by the oculomotor nerve, that is the superior rectus, the inferior rectus, the medial rectus, and the inferior oblique. Among all these four muscles, the three muscles have got the ipsilateral innervation, the superior rectus have got the contralateral innervation. It's simple to remember. Then there is a single subnucleus which I have drawn it in the center, which is basically the central subnucleus for both of the levator palpebrae superioris. So when we are saying that they are the paired nuclei, so each have a separate subnuclei which are present inside. But as far as this levator palpebrae superioris muscle is concerned, that does have a single subnucleus for both of the levator palpebrae. And there is a single Edinger-Westphal nucleus which is providing the preganglionic parasympathetic fibers to the ciliary muscles and the sphincter pupillae. Now here the thing which need to be kept in mind is that the fibers are going ipsilaterally to the inferior oblique, to the medial rectus, to the inferior rectus. But the fibers are going contralaterally to the superior rectus. But the contralateral fibers have a very important anatomical variation, because the superior rectus fibers coming from the opposite side, they go in close proximity to the ipsilateral fibers also. So a single nuclear lesion can basically responsible for the paralysis of both of the superior recti muscle.